Right. Good morning, everyone. So, as usual, our Wednesday's CME lecture will be done by endocrinologist, Kandy Hospital, Dr. Nayananjani Karunasena. So, amidst this ongoing COVID lockdown, we are still trying to keep up with our CME program, right? And I'm thankful to Nayananjani to taking up this topic. I mean, you'll never get enough of diabetes, like. So today she'll be talking on individualized approach to management of hyperglycemia. Nayananjani she had come to Kandy last year, right? And since we had the COVID, we didn't actually see her much, but she's around. She has been the consultant endocrinologist in several hospitals in Sri Lanka, Harapitiya, and General Hospital Nigambo, as well as Chilao. So she has done a service most of the part of Sri Lanka, and she's a graduate from Colombo, right? She's not from Peradine, she's a graduate from Colombo. She has got through her MD in 2012. She got a membership in 2013, and she has this special accreditation or certificate in endocrinology and diabetes from again Hba1c endocrinology and diabetes specialized uh, certificate as well from UK. Then there are so many things that she has in her CV, so I won't be spending time on that. And she was quite adamant that we should not read up this CV, right? So because of that, I'm going to give the podium to Nayananjani to talk to us on individualized approach to management of hyperglycemia. And please mute your mics when you're, especially if you're joining online. Thank you.
Thank you very much for those kind words of introduction. And good morning, ladies and gentlemen. And I would like to thank the KSM for once again inviting me to talk about diabetes. I think last year also I did a lecture on diabetes, and some of you may have been there, but I've tried to change the slides slightly in a different. I am trying to present it in a different way to actually to match the heterogeneous audience. So there are from consultants to medical officers. So some of you might find it is too less for you, and some of you find too much for you. So I have tried to suit it for everyone, right? So why are we talking so much about this diabetes? Because we are currently in a pandemic, we all know that. But before this pandemic, we talked about this epidemic, or rather sometimes we refer it to as a pandemic, the non-communicable disease pandemic or epidemic. And out of the non-communicable diseases, diabetes plays a major role. And if you look at the worldwide data, there are millions, like 450 million affected by diabetes as at 2015, and this is predicted to be predicted to increase by about 55% by 2040. And are we spared? No, not really, because we also, even being a small country, we know that our national data says the diabetes prevalence is about 10.3%, but I must stress that this data is kind of old. So this is kind of an underrepresentation of the actual data, but more recent studies conducted in areas like Colombo and Colombo suburb areas have shown the prevalence could be as high as 20 to 27%. So if you look at the IDF, the prediction of 55% increase by 2040, that means the numbers can be high as 30-40% by 2040 if we don't do anything to prevent this disease. So I'm not going to go into very big detail into the diagnosis of diabetes. This is something you all know. So there is normal category and then the diabetes group as well as the pre-diabetes group. So in order to diagnose diabetes mellitus, we need to have at least two tests above the normal range in the absence of osmotic symptoms. If the classic symptoms like polyuria, polydipsia are there, even a random blood sugar of more than 200 is enough. But otherwise, you need to have confirmatory tests, either same test repeated twice or two different tests. And it's also important to look at the pre-diabetes group as well, because as you know, that if you don't introduce the lifestyle intervention early in this group with pre-diabetes, they are very much likely to get diabetes during the next 5 years duration. So it's important to recognize that category as well, but I'm not going to talk about those at this during this talk. So brief look at the classification. Again, you know the type 1 and type 2 diabetes, and then the gestational diabetes mellitus. And then there are other specific types of diabetes, which include the monogenic diabetes syndromes, as well as the pancreas-related diabetes. But here again, I'm mainly focusing on the type 2 diabetes, which is mainly due to the insulin resistance, as well as the decreased insulin secretion as the disease progresses. So what are the glycemic? So before going into the deciding on what oral hypoglycemic medication or insulin that you're going to use, it's important to know what is your glycemic target for the patient. So we say as common guideline for all patients, we recommend Hba1c target of 7%. We see why it is actually in a minute. But those who are young and healthy and who do not have any other comorbidities, you can go for Hba1c targets even less than 6.5%. That is near normal. But those who are elderly and who have probably less life expectancy and have other comorbidities, and you can't achieve Hba1c of 7 without causing hypoglycemia, then probably you would be happy with Hba1c even around 8 or less than 8. And if the health is very poor, even 8.5 is acceptable. So why this Hba1c is so important? So let's look at this UK-PDS landmark clinical trial, which was done on type 2 diabetes patient, newly diagnosed. And according to this study, you can see that they not only they followed up these patients with type 2 diabetes for more than 10 years, and they have shown that 1% reduction in Hba1c is associated with significant reduction in all complications, like it's microvascular as well as the macrovascular complications and diabetic-related death in these patients with type 2 diabetes. So it's very important to understand that Hba1c reduction at the beginning of the disease is going to prevent the complication in long term for your patient. And where this 7% number came, actually in both UK-PDS and DCCT. DCCT is a trial actually on type 1 diabetes patient who are on insulin, who have started on insulin at the diagnosis. You can see that with Hba1c, if you look at this data from DCCT, when the Hba1c is 7 or less than 7, you can see that the risk of these microvascular complications like retinopathy, nephropathy, and neuropathy are very minimal. But as your Hba1c goes up, this risk is increasing rapidly. And this similar sort of data was shown with the UK-PDS. So that is one reason why this 7% magic number of Hba1c target has come. So if you can achieve 7% or less than 7%, that means you are going to reduce the long-term complications of type 2 diabetes. So when it comes to the diabetic medications, I think you saw in the initial video, so the sulfonylurea came into market in 1956, and then metformin was in the market from 1959 in countries other than United States. But you can see from 1956 to 1995, that is almost 40 years, there weren't any other oral medications. So I think, I presume the clinician at that time didn't have much debate about which medication to use. So they had only 2. But if you look at after 95, for the last 20 to 25 years, there have been lots of new medications that have come to the market, and the things have become more complicated, and you are challenged with the choice of medication you are going to use in patients. And to make the matters worse, you can see that this guideline from the ADA, so the guidelines also keep on getting complicated every year. So you're faced with the question, what you are going to give your patient. So that leads to the therapeutic inertia, what we call, that is the lack of adjustment of treatment regime when the patient's therapeutic goals are not met. So the idea of this lecture is to minimize and break this therapeutic inertia. So, let's look at the selection or the individualized approach. So again, I must say that diabetes management is a holistic approach. So it does not involve only the pharmacotherapy, but also the non-pharmacotherapy, which I have not mentioned here. So that involves the medical nutrition therapy and the lifestyle modifications such as the exercise. Any problem? No, okay. So that involve mainly the non-pharmacotherapy as well as the pharmacotherapy. When it comes to the pharmacotherapy, again, it's not just the diabetes management or the blood sugar control. It involves the other aspects as well, like reducing cardiovascular disease risk, like starting your statin and antihypertensives and various other medications. But I'm here going to focus mainly on the glucose control. So when it comes to the pharmacological management or the glucose control of diabetes, we can broadly categorize our medications into three groups, which includes the insulin, non-injectable, the insulins, and then oral anti-diabetic agents. And in between, we have the non-insulin injectable, the GLP-1 receptor agonists, mainly the you may have heard the liraglutide and all that. I'll talk about those later in this. Again, the categories or the groups of, I think most of the people who are here are familiar with these groups. So I will probably talk based on these drug classes rather than the individual drug agents. So we have the metformin and then the sulfonylurea, that is your glycoside, glimepiride, and the glibenclamide, and then the alpha glucosidase inhibitors, which has mainly acarbose, and then thiazolidinones. The only one available market is the 5-liter at the moment. These are kind of older medications, and the newer or more recent one, but not really new at the moment now, are the GLP-1 receptor agonists and the DPP-4 inhibitors, which are together known as the incretins. And then the SGLT2 inhibitors, the most recent and the most talked about and the glamorized oral anti-diabetic agent, I feel. Right. Okay, so so out of all these classes of medication, which one you are going to give to your patient is the question that we are going to answer at the end of this talk. So approach should be individualized, as we all know. And the main factors I want you to consider are the Hba1c reduction target. That is the patient's current Hba1c and what is the Hba1c target you have set for the patient, and how much how much Hba1c reduction you need. And then other comorbidities like cardiovascular disease and kidney disease are important. And then the weight. We see weight is a main problem in type 2 diabetes because they are most of the time overweight and obese. So you don't want to cause more weight gain. So you probably might have to cause weight loss. And then hypoglycemia is again a risk. Anybody who is on these medications or certain medications might be having high risk of getting hypoglycemia. So you need to prevent that also. And last but not least, the cost is a major issue, especially when it comes to countries like ours. Okay, so let's go through these factors and how you decide on treatment based on some cases. So these are actually theoretical or just I made up those cases, but these are based on things that you see in everyday practice. So you get a patient who is like a 45 years old banker, male person, who comes and complains of presence of osmotic symptoms for 1 month duration. And he has a BMI of 29.5. He's definitely obese according to the Asian cutoffs. So he has a fasting blood sugar of 256 and Hba1c of 9.5%. So what are the questions you have? The main questions are, so it is diabetes definitely because he has the osmotic symptoms and he's obese and he has a Hba1c of 9.5 and a fasting blood sugar of 256. So the diabetes diagnosis is confirmed. So you need to achieve Hba1c target at least less than 7% because he's a healthy young male. So, and the second thing that you need to do is promote weight loss and avoid any further weight gain as much as possible. So let's look at the guidelines. So if you look at the guidelines, metformin is the preferred initial treatment or the initial agent if there are no contraindication in any person with type 2 diabetes. Any new onset type 2 diabetes, metformin is the first line treatment. So that's something you have to remember unless patient cannot tolerate or if there are any contraindication. Once initiated, you can continue metformin as long as it is tolerated, but and not contraindicated. And you can keep on adding the second agent on top of metformin, including your insulin. So this second agent is the question we have. So you know the first agent is metformin, almost all patients. The second agent is what we have to answer. So if you think about our patient, we need to reduce the Hba1c by about 2.5% because he had a 9.5% and your target is less than 7%. Having said that, I must say that the lifestyle modification alone will reduce your Hba1c by about 1.5%. So you need to reduce at least another 1 to 1.5% Hba1c. So how are I going to achieve? So if you look at these individual classes of medication like metformin and sulfonylurea, the older drugs, you can see that Hba1c reduction can be up to 2%. So they are actually very good drugs as compared to these newer medications. So if you look at these newer classes like SGLT2 inhibitors or DPP4 inhibitors, that is your sitagliptin and alenagliptin and all that, their Hba1c reduction is 1% or even less than that. So these earlier medications are actually good in reducing Hba1c. And of course, insulin can reduce it to from 15 to even 6%. So I have just plotted it as 3.5%, but that can be more than that. So what do we know about metformin? Metformin is a drug, of course, everyone knows. So it acts by increasing the insulin sensitivity and reducing hepatic glucose production. And the good thing about is low risk of hyperglycemia, and it promotes modest weight gain, and there is good Hba1c reduction and quite safe to use. But the main concern is, of course, the renal functions when it comes to metformin. So it can be used. I have seen some patients tend to stop metformin when the moment the GFR comes even around 48 or something when they are in the CKD 3 stage. But that is not needed. You don't have to do that because you can use metformin until as long as the patient's GFR is more than 30 and stable. When it is less than 45, you have to actually reduce the dose. That is half of the maximum dose, that is 1 gram per day. But if it's a new patient and your eGFR is at the beginning is less than 45, you don't start metformin. When it is less than 30, only you have to stop metformin. And again, when it comes to cardiovascular safety, it is quite safe drug and probably have cardiovascular benefit as well because as shown in the UKPD's trial, which I showed earlier, but these are not, but these drugs didn't get the so-called cardiovascular outcome trials like the newer drugs because it was not mandatory at those stages. So still in our patient, so this patient, so initially you started with metformin and lifestyle modification. And after that, the patient returns in 3 months' time, and he has achieved some Hba1c reduction, but it's still slightly above the target, which is 7.8%, and he has not significant weight loss, and probably he was not compliant with his lifestyle modification as you have advised. So what are you going to do next? So let's look at the guidelines. So this is apart from the guideline which I showed earlier. So if it is the compelling need to minimize the weight gain or promote weight loss in your patient, after the metformin, your next choice is either a GLP-1 receptor agonist or a SGLT2 inhibitor. Failing that, you can add as the third agent, both interchangeably. And failing all that, if you need quadruple therapy, or if the patient can't tolerate the above 2 classes, then you can go for a DPP4 inhibitor, that is your sitagliptin or lenagliptin, the gliptins. And failing all that, only you should go for sulfonylurea and thiazolidinones like pioglitazone or insulin, because all these drugs are known to cause weight gain. So let's look at these drugs, the SGLT2 inhibitors and GLP-1 receptor agonists and the DPP4 inhibitors in a little bit more detail. So both the DPP-4 inhibitors and GLP-1 receptor agonists belong to the class called we commonly close as the incretin-based therapy. So what are these incretins? These are actually endogenous substances which are secreted by the gut. So you can see this the gut. So when you take your meal, particularly carbohydrate or sugar high meal, when the glucose is produced, these uh, substances called GLP-1 and GIP are secreted by the gut. And their action is to act on the pancreas, and they stimulate the beta cells to produce insulin and stimulate the alpha cells to reduce glucagon, thereby controlling the blood sugar levels. Uh, so, so these are the two naturally occurring incretins, the GLP-1 and GIP. And then there is this enzyme called DPP-4, and this DPP-4 is what is the action of that is degrading this GLP-1 and GIP. Thereby, this action or this pathway is completely blocked when this become activated. So what they did is they developed two medications based on this incretin pathway. One is the aiming the GLP-1 agonist, that is something which works like GLP-1, and then the DPP-4 inhibitor, that is something that inhibits this enzymatic action. So thereby prolonging the naturally occurring GLP-1 action. So what are these? That's how they came on. So that this DPP-4 inhibitor. So I think almost all of you are familiar with the drug class of the gliptins, the sitagliptin, vildagliptin, and linagliptin. These are all available in Sri Lanka, except for the saxagliptin and alogliptin. And what is the good thing about DPP-4 inhibitor? They are well tolerated medications, and the risk of hypoglycemia is very minimal, and the weight neutral. Does not really cause weight loss, but it doesn't cause weight gain as well. So they are weight neutral. So someone who is obese, that is a good choice of medication. But the problem is they need the dose adjustment in renal impairment, except for the linagliptin. Linagliptin, you can use it even low EGFR. But again, there is history of pancreatitis associated with these gliptins. So you should not start if there is past history of pancreatitis. When it comes to cardiovascular outcomes, they were proven to be neutral, which I'll show you later on. And then what are these GLP-1 receptor agonists? I think this is something some of you may not be familiar with because it's not widely or freely available in Sri Lanka. So out of these, this GLP-1 receptor agonist, that is this incretin, this natural the agent which is similar to this naturally occurring incretin, is available as actually only as a injectable, except for semaglutide. Semaglutide is now available in the oral formulation, but again, it's still not in the market widely because it's still at the research level and available in some countries, but not here. In Sri Lanka, you can get liraglutide and exenatide. Liraglutide usually given as a daily injection, but these other GLP-1 receptor agonists can be given as a once a week drug, which is very convenient for the patients. But unfortunately, these are very costly in our setting because it's not freely and widely available. So the good thing about them is they have shown to have weight loss. And this is, however, dose dependent. And particularly liraglutide is being approved as a weight loss medication, but at a higher dose than what we give for the diabetes patients. And again, they have the cardiovascular mortality benefit, which I'll show you later. And there is no risk of hypoglycemia. But the disadvantage is they are expensive, it's injectable, and they can have GI side effects like nausea, vomiting, and they have, again, similar to the DPP-4 inhibitors, risk of pancreatitis should not be started if there is past history of pancreatitis. And there is some risk story about risk of medullary thyroid CA, but this is mainly on rodents, so you don't have to really worry about that. So what are the SGLT2 inhibitors? So again, that is, I think, most of you are now familiar with SGLT2 inhibitors. The empagliflozin, canagliflozin, and the pagliflozin all are available in Sri Lanka. So if you look at the normal anatomy of the nephron, you know the proximal convoluted tubule of the nephron has the SGLT2, the transporter. The action of this transporter is to absorb 90% of the glucose, which is filtered through the glomerulus. So what is the action of this drug? The inhibition of this SGLT2 transporter is the action of this drug. That means this reabsorption of the glucose is inhibited, leading to glycosuria, that is renal glycosuria. So the usually in a normal person, 90% of the glucose filtered is absorbed through the SGLT2 transporter, but with the SGLT2 inhibitor, that is lost, and that leads to the renal glycosuria and reduction of the blood sugar. This class of drugs are actually a good class of drug because it's shown to reduce the blood sugar level as well as the blood pressure and the weight in the studies. And they are usually once a day drug, and the risk of hypoglycemia are very less. And there are benefit on cardiovascular disease as well and renal disease, again, which I'll discuss in the next case. But again, when you are initiating SGLT2 inhibitors, you have to be really careful about the patient selection because it has a weight loss effect. For obese patients, it's a good one, but if it is a thin patient, it might not be a very good one. And the risk of genital infections is very high. In males, they might get lots of balanitis, and then in females, they can end up with vaginitis. So if they complain any of those things, you need to stop these medications. Don't continue if they develop. And they can, in rare instances, you can see Ponius gangrene in males, but I have never seen, but I think Charles has seen, as he says. And there was some thought about this amputation risk as well associated with this medication, but this was later disproven in some of the most recent studies, but should be again cautious, especially those who have peripheral vascular disease. And the other important thing is, remember, is the diabetic ketoacidosis, DK. They can get what is called euglycemic ketoacidosis. That means their blood sugar won't be high, but they can have ketoacidosis. So you have to be vigilant and do urine ketone bodies if you are suspecting DK in these patients. Okay, so let's move back to our patient. So he's what is the next medication that is more suitable for them? So based on his weight and Hba1c reduction need, we could go for a SGLT2 inhibitor if there are no contraindications, and GLP-1 receptor agonist if affordable. And you can even consider like something like sitagliptin if both above are not affordable or not desired in that patient. Okay, let's move to another patient. So it's a 72 years old male who comes with a history of hypoglycemic episode, mainly in the night, and he has a Hba1c of 9% and a GFR of 58, and a microalbuminuria, which is just very mild, and a BMI of 22. So he's already on metformin 500 BD and glibenclamide 7.5 milligram BD. So what are the problems in this patient? So are you happy with the Hba1c target or not in this patient? Yeah, most likely, even though he's 72, it's still a bit high. But the problem is you need to prevent further hypoglycemic episode when you are adjusting the medication of this patient. And the weight, is it a problem? No, I don't think so, because his BMI is 22, so it doesn't matter even if we gain a little bit of weight. And the renal safety, you don't have to worry that much because his creatinine eGFR is still fairly good with mild microalbuminuria. So what does the guideline say? So this patient's main problem is hypoglycemic episodes with poorly controlled diabetes without any significant comorbidities. So if the compelling need is to minimize hypoglycemia, then you can go for, as the second line agent, DPP4 inhibitors, GLP-1 receptor agonists, and the SGLT2 inhibitors, which you already discussed. But again, in this patient, because he has a low BMI, probably GLP-1 receptor agonist and SGLT2 inhibitors might not be very good. But the DPP4 inhibitors, yes, you can consider. And the other option is the thiazolidiniones. Thiazolidiniones, let's see why it might not be a good option in this patient. So he's already on a sulfonylurea. So sulfonylurea are your, all of you know, it is the insulin secretagogue, which stimulates insulin release from the pancreatic beta cells. And it's a very good drug because it has a very good Hba1c lowering effect. But the problem is, most of the time patients complain of the weight gain and hypoglycemic episode are quite frequent with this medication. So these are the available sulfonylureas. So if you look at this hypoglycemic risk is actually high with drugs like glibenclamide and glimepiride because of their longer duration of action, and particularly high risk in elderly patients. So the efficacy is same, but the drugs like long-acting sulfonylurea like glibenclamide should be avoided in elderly patients, particularly because there is increased risk of hypoglycemia. And the newer sulfonylureas have low risk of hypoglycemia. So you can choose new newer sulfonylurea like glycoside if you want to really give a sulfonylurea. And it's safe in renal failure, but again, the problem is hypoglycemic risk can be higher. And yeah, and then the thiazolidinone. So according to this guideline, so if your need is to minimize hypoglycemia, you can give thiazolidinone as well. So the only available thiazolidinone at the moment is a pioglitazone. It's again an insulin sensitizer like metformin. It can be given once a day, which is a good thing. And it has also shown to reduce the progression of glucose tolerance to chronic diabetes. And it's quite a good drug when it comes to glycemic control, except for, but it has very bad side effects. So you have to be careful about those things. Particularly the weight gain and fluid retention. In a patient who is already obese, you don't want to give this drug. And it can cause worsening heart failure as well due to the fluid retention. So if the patient already have ischemic heart disease and heart failure, please don't start. And then the macular edema also can be worsened. And there might be increased risk of fracture because of this action on the PPA gamma pathway. And the bladder cancer, of course, is controversy. There was earlier some concern, but it was later disputed, and it was said there is no increased risk of bladder cancer. Right. So going back to our patient, so we are not very happy with Hba1c he has. So we probably can go for like less than 8% target because he's 72 and there are risk of like recurrent episodes of hypoglycemia. So you can be happy with Hba1c of 8 or less than 8. So to prevent further hypoglycemia, you might have to reduce or stop the use of glycoside, and you can add something like DPP-4 inhibitor like sitagliptin. So your weight is, you're not that much worried because he's not that obese, and renal, as I said, not a major issue. Okay. Let's look at the next patient. So it is a 58-year male with type 2 diabetes for 10 years and recent history of non-STEMI, and Hba1c is 8%. Sorry. And GFR is 68, and he's already on metformin 1 gram BD and glimepiride 4 milligram BD, 2 oral hypoglycemic medication at maximum dose, and a BMI is 26. So are you happy with the Hba1c target of this patient, or you want to reduce it further? So it's a young male, non-STEMI, but otherwise it's fit and young. So you can consider reducing the Hba1c further. And the weight, he's slightly overweight, but not obese. So you have to be cautious anyway. And the other main thing is his comorbidity of cardiovascular disease. So if there are, when it comes to the next treatment option in this patient, the main thing you are thinking about is the cardiovascular safety as well as the cardiovascular benefit. So if you look at the guidelines, so this is again a complicated part. So I have taken out only this bit and put it here. So if there are patients with ASCVD or indications of high risk for cardiovascular disease, such as age more than 55, coronary artery disease, or peripheral vascular disease, then your the best second line agent is the GLP-1 receptor agonist, which has proven to have cardiovascular disease benefit, or a SGLT2 inhibitor with proven cardiovascular disease benefit. So again, the same thing is here. And what is this cardiovascular benefit they are talking about? I have not gone into detail of the individual cardiovascular trial. The newer medications, when they need the FDA approval, they were asked to do cardiovascular safety trial because in the past there has been some cardiovascular safety concerns with drugs like rosiglitazone. So all these new classes of medications like DPP-4 inhibitors, GLP-1 receptor agonists, and SGLT2 inhibitors have undergone these cardiovascular safety clinical trials as a part of their requirement to get the FDA approval. So out of these trials, we have got very good results and actually have been made able to change our guideline based on that. So if you look at the DPP-4 inhibitor, all cardiovascular safety trials, they are shown to be neutral. That means there is no increased cardiovascular risk, but there is no increased cardiovascular benefit as well. So they are safe drugs to use in those with cardiovascular disease. When you look at the GLP-1 receptor agonist, except for the lixisenatide, the other drugs like liraglutide, semaglutide, and exenatide all have shown to have cardiovascular benefit. That is the cardiovascular outcome. There is the risk of dying from cardiovascular disease and etc. were improved or reduced with use of these medications. And similarly, the SGLT2 inhibitors, the landmark trials like ENCOURAGE, CANVAS, and DECLARE all have shown that there is the cardiovascular benefit with these medications. So those who have cardiovascular disease and increased risk of cardiovascular disease, these are good drugs or better drugs when compared to the other classes based on these evidence. Okay, so our patient, so we try to reduce the Hba1c at least to 7%. So he's slightly overweight, so it doesn't matter even if he lose some weight. And so he needs some drug which has cardiovascular benefit or safety. So preferably SGLT2 inhibitor or GLP-1 receptor agonist you can start. So in our setting, probably SGLT2 inhibitor, which is widely available, and oral drug, because GLP-1 receptor agonist is injectable and quite expensive. So the next patient I want to look at is a 56-year-old female having type 2 diabetes for 5 years, comes to you with a bilateral ankle edema, normal urine output, and frothy urine, and found to have a BMI of 25 and blood pressure of 130/80. And Hba1c is 8%, and GFR is 40, and urine for microalbuminuria is more than 300 milligrams. So this patient is already on metformin, 1 gram BD, glycoside MR 60 BT, and Bisartan, the ARB 150 BD, the maximum dose. So again, this patient, what is your Hba1c target? Probably you can reduce it little further. His Hba1c is still 8% because she has evidence of microvascular disease, that is microalbuminuria, and mild reduction of the GFR. So he ideally the Hba1c target should be 7 or less than 7% in that sort of a patient. So you have to reduce the Hba1c, but the problem is the GFR is slightly low, and the proteinuria is there. So these are the things that we want to address. So then, if you look at the guideline, so if there is evidence of CKD and albuminuria, the next treatment that you are looking at probably is SGLT2 inhibitors with evidence of reducing CKD progression, or GLP-1 receptor agonist. So what are the, why are we saying like that? So I think the cardiovascular trials that I mentioned earlier, most of the trials, they have shown that they reduce the progression of the renal disease in these patients with type 2 diabetes and particularly albuminuria. But all those studies were mainly aimed at, they were designed as cardiovascular safety trials. But apart from that, the later on came the studies like Credence, which is particularly designed to look at the renal outcomes in patients with type 2 diabetes and presence of albuminuria by giving SGLT2 inhibitor. Whereas I won't go into the details of the study. So this is one of the landmark trials which came, showed that according to this, this was actually using the canagliflozin and placebo in patients with type 2 diabetes with GFR between 30 to 90 and microalbuminuria. That is actually macroalbuminuria more than 300. And this trial showed that compared to the placebo, the SGLT2 inhibitor was associated with significant reduction with microalbuminuria. And also, their primary outcome was doubling of time to double the serum creatinine or renal or cardiovascular death and end-stage kidney disease. And as compared to the placebo, the canagliflozin was much superior when compared to the placebo. So in this patient, so the Hba1c target we were talking about probably 7% or less than that. So we need to reduce at least by about 1%. And weight, you can actually reduce a little bit of weight, but you might. So the Hba1c, sorry. So considering the renal safety, again, this patient, we can start a SGLT2 inhibitor in order to achieve our Hba1c target. Right. So I go to the next and the last case. So it's a 55-year-old female with type 2 diabetes for 15 years and come to you with the asthmatic symptom and complain of weight loss for 5 kilograms over the last 1 month. And she has very poor appetite and she looks very ill and a BMI of 20, and Hba1c of 11 and eGFR of 68. So metformin, she's already on metformin 1 gram BD and glycoside 160 BD. So what are you going to do with this patient? What would be your next treatment for this sort of patient? Anyone like to give answer? The trainees should be able to give. Yeah. So I think we talked about all these oral hypoglycemic medications, but this patient, obviously Hba1c is way far higher than our target level of 7 and needs a dramatic reduction of Hba1c and already lost weight. So most of the drugs that we were talking about might not reduce the Hba1c adequately. And above all, her main problem is she has significant weight loss. So there is evidence of catabolism. So in that sort of patient, you need to prevent further weight loss. So the answer is insulin in that patient, that sort of a patient, most likely. So according to the guideline, so if there is evidence of ongoing catabolism, that is by evidence by the weight loss and severe symptoms of hyperglycemia and Hba1c more than 10% at the presentation, along with above symptoms, most likely, the best treatment option is insulin. I'm not going to talk about insulin because it's going to be another different talk if we start talking about insulin. So, and the last bit of the guideline on oral hypoglycemia. So, if it's the cost is the major issue, what are you going to do? So, unfortunately, when it comes to management of our patient, probably this is where we are left at. Even though we talk about all these fancy drugs and injectables and everything, at the end of the day, probably we'll be prescribing sulfonylurea and thiazolidiniones because as well as the insulin, if the cost is a major problem. So this could be the problem in our patient most of the time. So this is just to summarize the drug classes and their the hypoglycemic risk and weight loss and all that. So I'm not going to go into details. So just to sum up what I tried to do today. So the approach to choice of antidiabetic agent is individualized based on the individual factors like Hba1c, age, and other comorbidities as well. And metformin remains the first line of agent. And those who have high risk of established CVD, CKD, or heart failure, then the SGLT2 inhibitors or GLP-1 receptor agonists should be considered as the second line agents. So in other patients, you can choose the second line agent based on their weight and risk of hypoglycemia as well as the cost. And insulin should be started promptly if you fail to achieve the Hba1c target when and where appropriate. And it can be initiated with a basal insulin, but should prevent over-basalization, which actually I didn't go into detail. Right. So that's it. Thank you very much for listening. And I would like to answer if there are any questions. I don't know whether I made it even more complicated or made it simpler. Any questions or comments? Nothing. Either you understood everything or didn't understand everything. Anything. Okay, thank you very much.
You are currently the only person in this conference. You are currently the only person in this conference.